Good morning, everyone. Good morning and welcome.
Good morning.
And happy Friday to everyone. We are going to give it just a few minutes to give folks time to sit down and settle in and log on. In the meantime, for those of you who are here, welcome. Please feel free to share your name and your organization in the chat so we know who's here with us today. Good morning and welcome. Good morning, Dr. Scott and Jen. Good morning and welcome. To everyone who has just joined us, welcome. And we're giving it just a couple minutes so folks have a chance to log in, log on. You can introduce yourself in the chat if you haven't done so already. Good morning, Lorena. Good morning and welcome. For those of you just joining us, good morning and welcome. We're just giving it a minute to give folks a chance to log on and settle in. If you haven't introduced yourself in the chat, please feel free to go ahead and do that. We'll get started in just a minute. Good morning and welcome to those of you who are just logging on. Happy Friday. We're going to get started in just a minute. And if you haven't introduced yourself in the chat, please feel free to go ahead and do that. And I think it's time. Let's go ahead. Good morning, everyone, and welcome to today's webinar. My name is Laura Brooks, and I'm with the Community Mental Health Board of Oak Park Township. For those of you who are new to our professional development workshops, welcome. And for those who have been here before, we're glad you're back. Welcome back. On behalf of the Mental Health Board and River Edge Hospital, thanks for taking the time to be with us today. In addition to our speaker, who I'll introduce in a moment, I'm joined here today by my colleague from the Community Mental Health Board, Melissa Lobring, as well as by Fatima Villasenor from River Edge Hospital. Before we get started, we have just a few housekeeping items to go over. First, our speaker would like this to be an engaging workshop. So if you haven't done so already, please feel free to introduce yourself in the chat, just your name and your organization, so we know who's here with us. If you are experiencing any technical difficulties during today's webinar, please chat just the hosts, and we'll do our best to take care of it. Next, our presenter has saved some time for Q&A. If you have questions for him, feel free to drop them into the Q&A so we don't lose them in the chat. Also, he has built in a brief break midway through today's presentation, so we'll all have an opportunity to step away a little bit for a few minutes to grab a coffee or a tea or a water or just stretch or do whatever we need to do to take care of ourselves. Finally, and importantly, I want to cover CEU procedures. To be eligible for CEUs, you must participate in at least 75% of today's webinar, and you also must fill out an evaluation by the deadline. Due to requirements implemented by the state related to CEUs for virtual workshops, you will now also have to complete a post-test, passing with a score of 80% or greater in 3 attempts by the deadline. We will post a link to the evaluation and a link to the post-test in the chat at the end of today's webinar, so you'll be able to fill them out immediately. We will also email those links later today. Both the evaluation and the post-test will be open for 1 week through Friday, August 14th. After the evaluation and the post-test close, CEU certificates will be emailed within 2 to 3 weeks to those who attended at least 75% of today's webinar, submitted an evaluation, and passed the post-test with a score of at least 80% in 3 attempts by the deadline. If you have any CEU questions, please feel free to get in touch with us through Eventbrite. We'll be happy to help you out. Finally, please note that the registrant links to access this webinar are unique to each participant and they are non-transferable. Registrants may not share their individual access links with other users. Sharing links can cause security and attendance tracking issues, prevent other registered attendees from being able to join, and cause audio or connection instability for users. We have to let you know that users who violate this policy may be removed from a webinar and restricted from accessing future webinars. Okay, all that fun stuff is behind us now. Without further ado, let's get started with today's presentation. We are so pleased to have Scott Sanders back with us today to present his workshop, Beyond Traditional OCD, Atypical OCD in Individuals with Autism and Intellectual Disabilities. Scott is a board-certified behavior analyst with the support services team of the Illinois Crisis Prevention Network. Over the course of more than 20 years in the field, his work has involved providing behavior analytics services to a wide range of individuals who experience stigmas associated with their mental health. As a result of these experiences, he developed a passion for advocacy, championing social justice, and providing psychoeducation about mental health to the general public. In today's webinar, Scott will share information about the co-occurrence of obsessive-compulsive disorder with autism or intellectual disabilities, which often presents atypically and remains underrecognized. Atypical OCD manifestations characterized by unusual obsessional content, communication challenges that obscure intrusive thoughts, and compulsions that may appear indistinguishable from restricted repetitive behaviors pose significant diagnostic challenges and diagnostic overshadowing, where symptoms are incorrectly attributed solely to autism or intellectual disability, frequently delays appropriate treatment, and contributes to unnecessary polypharmacy. In today's session, Scott will provide an overview of atypical OCD, help us understand the difference between autism-related behaviors and OCD-driven compulsions, provide guidance on how to recognize common atypical OCD presentation in individuals with autism or intellectual disabilities across both verbal and nonverbal examples, and more. With that, I'm pleased to turn it over to Scott.
And thank you, Miss Laura. That was a fantastic introduction, and I am very happy to be back and talking with everybody today. And thank you for that wonderful introduction, because today is about one of those advocacy things. Atypical OCD is something that I've become interested in the last couple of years, and so I'm glad to start a little conversation this morning. So thankfully, Miss Laura took care of most of the learning objectives that we're going to cover today. We'll define atypical OCD and identify some features that distinguish it. Want to differentiate between autism-related RRBs and OCD-driven compulsions, recognize some common atypical presentations, explain some diagnostic overshadowing and how that contributes, identify some polypharmacy patterns and those that are associated with unrecognized atypical OCD, and guide families and clinicians in how to effectively communicate these concerns to physicians, because thus far the response has been somewhat mixed. So let's just begin. Individuals with autism spectrum disorder and intellectual disabilities frequently present with behavioral patterns that closely resemble obsessive-compulsive disorder. These are highly stereotyped, invariant response chains, extreme distress when escalation chains are interrupted, and apparent relief following the completion of these compulsions. And over time, these behaviors become progressively entrenched and resist conventional intervention. Standard OCD diagnostic criteria and most evidence-based interventions typically rely on verbal reports of obsessional cognition, which makes it pretty poorly applicable to this population. Even existing behavioral accounts have not adequately I differentiated compulsive relief cycles from other automatically maintained or negatively reinforced behavior classes, leaving clinicians without a functional framework that accurately characterizes the maintaining variables or informs assessment and treatment. Okay, so let's address the elephant in the room right from the get-go. Atypical OCD isn't actually a thing. It's not. I kind of made it up. Not completely, but it's not a formal diagnosis that is in the DSM-5. So if you pull open the DSM-5, you're not going to find reference to atypical OCD. Atypical OCD refers to obsessive-compulsive disorder presentations that deviate from classic patterns typically seen in neurotypical populations. This subclass of patterns closely resemble obsessive-compulsive behavior in their form and functional properties. These are highly stereotyped, invariant response chains that appear to be triggered by very specific internal or contextual antecedents, produce apparent relief upon completion, and become progressively more entrenched over time. These presentations are pretty well documented in the literature and are associated with higher significant clinical burden, higher caregiver distress, and an elevated risk for self-injury when compulsive behaviors involve dangerous topographies or when interruption produces severe behavioral escalation. So, how did this thing come about? So, about 2 years ago, I got a couple of clients on my caseload, about 3 or 4, almost back to back. And almost every single situation had a very similar pattern to it. The situation was that let's say a family had a loved one with autism, and at some point in time, this person's behavior changed dramatically. Maybe they were engaging in some OCD stuff that, the family was able to accept, but at some point, the OCD behavior, the compulsions that the person was engaging in became maladaptive enough that something had to happen. And eventually, the family may have sought out services of a doctor who, when they went and talked to the physician about what was happening, they said, here's the thing. My loved one got upset. They get upset out of nowhere. When I'm redirecting them from doing something, they get upset and they hit me. And this just isn't who they are. And I don't understand it. And it feels really impulsive. And the doctor hears that and tries a medication. And unfortunately, there were multiple trials and multiple situations where the medications weren't necessarily the answer because they may not have been treating what it was that was going on. And in each situation, after looking at the variables, the behaviors that the person was engaging in were very similar to OCD, but due to these classification problems, it was impossible to define and be able to talk with doctors about what was going on for this person. And so, in order to define atypical OCD, I think we need to first start with what does the DSM-5 say OCD is? So if you look at the DSM-5 criteria for OCD, the first part is presence of obsessions, compulsions, or both. Obsessions are defined as recurrent or persistent thoughts, urges, or images that are experienced as intrusive and unwanted, and that cause marked anxiety and distress in most individuals. I think that's an important one because all that has to happen is the person can experience what is happening with regards to the obsession. The individual attempts to ignore or suppress such thoughts or images or to neutralize them with some other thought or action, i.e., a compulsion. Compulsions are defined by repetitive behaviors that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. Also note that in this definition, it doesn't say that the rules need to make sense. It just means that they have to be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. The obsessions are time-consuming, so this is one that definitely makes it difficult for this population. The time-consuming, taking more than an hour a day, engaging in compulsive behaviors. As we'll talk about today, sometimes with atypical OCD, the complete compulsion contingency can happen within seconds or moments. Obsessive-compulsive symptoms are not attributable to other physiological effects and not better explained by symptoms of another mental disorder. So some of the diagnostic challenges that come as a result of this very strict definition. Insight assessment requires self-report. In essence, in order for a doctor to truly diagnose somebody with OCD, currently, the person has to be able to verbalize obsessive thought content and be able to express that they engage in compulsions to a physician. That makes it impossible for nonverbal individuals to communicate those same things with physicians. Traditional OCD diagnosis relies heavily on self-report of internal experiences. If the person can't tell you, do they really have it? Nonverbal individuals cannot describe these as obsessions, making it extremely difficult to distinguish compulsions from stereotypy, self-stimulatory behavior, or other repetitive behaviors that are common in autism. Behavioral assessments often indicate an automatic function due to the lack of an observable antecedent, or assume an escape function to escape an aversive internal stimulus. So, some other relevant features about atypical presentations. One of the critical features may be the age of the onset as well. OCD symptoms tend to emerge later in life. Autism spectrum symptoms are generally from childhood, and so if the person is engaging in restricted repetitive behaviors from very early age, that may be indicative of autism. If around the teenage years, a form of OCD becomes much more excessive or begins to affect the person's life maladaptively, that may suggest OCD symptoms. Another defining feature of atypical presentations is the amount of distress and resistance to interruption of compulsions. Unlike autism-related repetitive behaviors that are often pleasurable or self-soothing in some way, OCD compulsions typically cause distress when the person is interrupted, and they show resistance and frustration when prevented from completing the compulsion. In fact, can get to somewhat dangerous topographies in order to complete the compulsive behavior. OCD behaviors also typically interfere with daily functioning in ways that are distinct from autism-related challenges. I have a young man that I work with who engages in a lot of autism RRBs throughout his day, and sometimes as he's engaging in an RRB, a OCD contingency will happen. And then the next thing you know, he is engaging in that RRB for the next 45 minutes to an hour until the just right phenomenon is met. Going back to the distress and the resistance, that response to interruption, autistic stereotypies often easily are redirected, or most of the time are able to be redirected. OCD compulsions often show persistence, agitation, and escalation when the person is interrupted, and they can often result in physical aggression, property destruction, or self-injurious behavior in order to complete the ritual or routine. And so how are we doing with regards to behavior analysis? This one was a tough one for me as a behavior analyst, but it was a moment of realization as well. Existing behavior analytic accounts of OCD have often conceptualized OCD through the lens of either escape-maintained behavior or automatically maintained behavior. The most common clinical response is to categorize atypical OCD behavior as escape-maintained. The individual is trying to escape some internal discomfort and to apply a standard extinction-based procedure, often with poor results. I was absolutely shocked when I started doing a lit review and looking through all of the literature that was associated with behavior analysis and OCD, and it absolutely was true. In the literature, you'll often find extinction functions for behavior. And they'll say, well, this person, it appears that this person is trying to escape an internal physical discomfort. And so we're going to engage in this intervention. It's going to be extinction based. Once the person's no longer able to get that response, then they will stop engaging in this behavior. And that logic is not completely wrong, but it does fail to think about or take into account a couple of features that are characteristic of compulsive presentations. First off, the high specificity sometimes of the eliciting antecedent. As we'll talk about a little bit later in a number of examples of atypical OCD, sometimes there is a very specific eliciting antecedent, either internal or in the external environment, that the person is responding to. There's also extreme topographic invariance of the response chain. So in terms of escape maintain behaviors, oftentimes with escape maintain behaviors, people can engage in a variety of escape maintain behaviors to get the same outcome. With OCD compulsions, the person feels restricted to one topography of behaviors is the thing that is going to produce that conditioned relief cycle. And so it is an invariant response chain, and only one topography in the person's mind is the one that will produce the relief sensation. Third here, the conditioned reinforcing quality of the relief that follows the chain completion. So once a person has engaged in the compulsion, the relief that they experience as a result of for having done it is actually a conditioned reinforcing property that becomes more compounded over time as well. The progressive entrenchment that occurs even in the absence of social reinforcement is another key feature that is not to be misunderstood here in this contingency. Again, behavior analysts are suggesting that a person is engaging in escape maintain behavior to get rid of an internal uncomfortable physical stimulation. And so that doesn't have to happen in the presence of other people or in the presence of social reinforcement, right? The person can engage in these compulsions without anybody ever seeing them, and that behavior is still reinforced automatically within that person's own body. As I said, the categorization of OCD, atypical OCD behavior as escape maintain is not inaccurate, but it does obscure some important functional distinctions. Generic escape maintain behavior is maintained by the termination of an aversive event, typically an identifiable environmental stimulus, such as a demand, a loud noise, unpreferred activity, somebody asking you to do something, right? The response class itself is typically flexible in topography. A variety of responses can effectively terminate the aversive event, and the individual will emit whichever response is most readily available and least effortful. Let's take an easy one. If a fire alarm starts going off, right? There are a variety of behaviors I can engage in to get this fire alarm to go away. I can leave the room. I can exit the building. I could find the alarm and try to turn it off. All of those things are response class behaviors that would ultimately produce the same outcome. The behavior is also sensitive to extinction. With escape maintain behavior, that behavior is sensitive to extinction. So if the person is engaging in a behavior and that behavior no longer produces the escape that it once did, the person will find another behavior that produces that same amount of relief. If I try to escape the fire alarm by leaving the door, but the door is locked, I will try to find another door to leave, right? The behavior is sensitive to extinction and responds to it. The aversive antecedent is typically exteroceptive, meaning it's in the external environment, observable to the behavior analyst doing the assessment, and at least is indirectly accessible through standard functional analysis conditions. We generally are able to see what it is that the person is wanting to escape. Atypical compulsive behaviors differ from generic escape maintain behavior on each of these dimensions. First off, the antecedent is characteristically conditioned aversive interoceptive stimulus, something that is happening within the person's body that we may not be able to see, rather than an external physical cue. The response class can also be extraordinarily inflexible. Not just any behavior terminates that aversive feeling, but only the specific topographic sequence that has historically produced that same conditioned relief. And the maintaining consequence is not simply the termination of that aversive event, but the production of that conditioned relief as well. A conditioned positive reinforcer tied to the specific proprioceptive and contextual stimuli produced by the completed response chain, meaning that it's not just, getting done with that thing, but it is the relief that is produced within that person's body. Again, if the first triggering thing was an internal state change where the person became agitated or internally, it was aversive, the conditioned relief is the part of the contingency where that person's internal state goes back to baseline responding calm. And the behavior is highly resistant to extinction because the behavior is highly resistant to extinction because the condition aversive interoceptive stimulus is actually an MO, a motivating operation, and does not require environmental management to be reinstated. So what this is talking about as well is even if a person is engaging in an atypical compulsive behavior chain, I will use, for our example today, a person who tears the tags off of other people's clothing. When this is happening, it does not require environmental management to be reinstated. If a person is walking through the mall and sees a tag on somebody's jacket, runs over, tears the tag, the conditioned relief is produced by after the tag is torn and the person realizes the compulsion is completed, they then go back to that baseline responding. If the person then sees another person's tag, runs over and does that, the response chain has in essence been reinstated and starts back over and can happen within a matter of seconds. And now the big one, or what I thought would be the big one, the automatic reinforcement misconception. Atypical compulsive relief cycles must also be distinguished from automatically maintained behavior, which is a common maintaining variable for stereotypy in individuals with autism, as well as individuals with intellectual disabilities. Automatically maintained behavior is characterized by a relatively consistent rate that is not strongly modulated by MO fluctuations, flexibility in topography across variations that produce that same input, and response patterns that are not specifically tied to identifiable aversive antecedents. Atypical OCD, by contrast, shows that has a rate that is strongly modulated by the intensity of the condition internal aversive MOs, extreme topographic rigidity, and a clear temporal relationship between aversive antecedent conditions and behavioral initiation of the compulsion. Distinguishing these functions has important treatment implications as well, because those sensory extinction or sensory competition type interventions that we as behavior analysts have been doing for many, many years are unlikely to be effective for atypical OCD behavior, whose maintaining variable is the condition aversive MO rather than sensory reinforcement. So this one's a big one for me, and I say that this one was, for me, a shocking one in that, yes, I was shocked that when I went back to the literature to find that more often than not in behavior analysis, we generally characterize OCD behavior as escape maintained in the literature. But in my professional experience over doing this job for many years and working with other behavior analysts, many individuals who run across OCD type behavior often come into the struggle that once we've done some functional analysis, even indirectly, more often than not, the function comes up, automatically maintain behavior. And I myself, as a behavior analyst, have been guilty of this for many, many years. And for a very, very simple reason. A doctor that I used to work with many years ago, who I loved and respected very much, he taught me everything I know about psychotropics and many other things. Um, I can remember there was a day where we were doing a psych review, and at the time I was clinically supervising a group home of young teenage boys with autism. And during one psych review, one of the case managers kept referring to he's engaging in OCD. He's engaging in OCD. And I will never forget the doctor stopping the meeting and saying, "Hey, just so everybody knows, people with autism don't really have OCD. All right. I know it kind of looks like it. I know it kind of feels like it, but if they have autism, we just call it, OCD-like behavior. Can we just say that from now on?" And for the next, I don't know, 15 years of my career, I would continue on under the assumption that a physician had told me that people with autism don't necessarily have OCD, that more often than not, it's really just the autism, it's an RRB, the person kind of likes what they're doing. And I just kind of went with that. I too had functional analyses that came back automatically maintained. And so there were multiple times where I thought, man, what kind of intervention can I have? This person has an automatically maintained behavior that all of the reinforcement's happening internally. How can I compete with that? How can I put that on extinction? Behaviorally, I was in the same place. And then a few months ago, as I've been doing this, the research and some work on this, I realized something about our misunderstanding about automatic reinforcement as I was working with an individual with an atypical OCD presentation. The behavior analyst I was talking to kept referring to the person's OCD as automatically maintained behavior. And I said, okay, I understand that. At the same time, my understanding of automatically maintained behavior is that the person is engaging in a pleasurable, self-soothing form of behavior. It is something that they like doing and that they seek that reinforcing property. And they said, yes. And I said, does this really seem like this person is happy while doing this thing? Because they seem really distressed. And they said, well, they are distressed. And I said, okay, so if the person's really distressed, is it really an automatically maintained behavior? And it took that person a moment to really think about the question that I was asking, which was, if we're saying that is a pleasurable, self-soothing behavior, shouldn't it be pleasurable and self-soothing and not cause the person distress? And so something was missing in terms of that misunderstanding of where that maintaining variable comes from and how it impacts the individual with atypical OCD. All right. So now that I've used a bunch of words to describe a whole bunch of things up to this point in time, what are those three distinguishing features that make atypical presentations different from typical presentations of OCD? My first point of contention is the limited verbal expression of obsessions. In atypical presentations, obsessions may be non-verbally expressed through behavioral indicators instead. A person may not be able to tell you what's happening, but you can see distress. You can see their agitation about this thing or their avoidance of that thing. Secondarily, atypical compulsion patterns. Because the classic rituals like hand washing and checking on doors and locks and things like that are the things we typically think about. Atypical compulsions may actually appear as unusual ordering or arranging that differs from typical autism-related preferences. Excessive question asking or reassurance seeking that exceeds the developmental expectations. Compulsions embedded within or disguised by autism-related stereotypies, and aggressive or self-injurious behaviors serving anxiety reduction functions as well. The third point of contention here is context-dependent presentations. Unlike OCD, where symptoms are relatively consistent, symptoms may intensify dramatically in specific environments or with specific people, specific caregivers. Compulsions may be more situation-specific and appear more behavioral than ritual-based because of these context-dependent presentations as well. The individual may show extreme distress when unable to complete the compulsions, but struggle to explain why. All right. So now that we have made a case for a couple of defining features of atypical OCD and why that is so different and how we can maybe characterize it different than the traditional DSM approach, here is my best guess at trying to explain atypical OCD from a behavioral perspective. Functionally, atypical OCD can be characterized as a specific and identifiable antecedent condition, either environmental or interoceptive, that reliably precedes the initiation of a compulsive behavior. A response chain that is highly invariant in its topographic sequence, such that interruption or modification of the chain produces extreme behavioral escalation. A post-response period characterized by behavioral indicators consistent with a reduction in aversive arousal, what people generally see as a person calming down or going back to baseline, and progressive entrenchment over time, such that antecedent conditions come to exert increasingly strong control and broad control over the compulsive response, and the response itself becomes increasingly resistant to modification. So I put these things out there behaviorally and explained it from a behavior analytic perspective because I want to at least put out there the idea that from a behavior analytic perspective, respondent conditioning can establish aversive functions of stimuli, and operant negative reinforcement can sustain the compulsive responding independent of language or verbal mediation. So let me explain this behavioral explanation. Take, for example, the gentleman who tears tags off of other people's clothes, right? I have an individual, or I work with an individual who has this specific target behavior. And so as you're walking through the mall with Bobby, it is not uncommon that the first part happens, a specific and an identifiable antecedent condition. Now, it may be that from an outside perspective, we're looking at the presence of somebody else's tag on a clothing as the antecedent. And while that is accurate in that is what the person is responding to, and ultimately the compulsion has to involve, at the moment the person sees the tag, it is not the tag itself that causes the person to respond. But when they see the tag, it causes an internal aversive stimulation in their body that causes a change in that person. So that identifiable antecedent condition may also involve a change on the part of the person. With my individual in particular, his facial expression changes. Looks like a surprise. Oh my God, there's that thing. And then his body tightens and he runs over to the tag and he grabs the tag and he pulls, right? So that's the B portion. The response chain is highly invariant to the topographic sequence. Once he sees that thing and gets that surprised look, he has to run at that thing and grab that thing, and he has to pull that thing. If there's any interruption to that, he may become physically aggressive with the person who is attempting to stop him from engaging in that compulsion. Once he has torn that tag, you can see the relief come over his face. His facial expression changes, body language changes as he's dropping the item to the ground. And regardless of any interventions, regardless of medications, regardless of any social contingency, this young man has engaged in this target behavior for a number of years without any decrease to the behavior. I say all these things behaviorally because what never happened at any point in the chain was verbal mediation, meaning the verbal community, the people around that person, may have been telling that person, no, stop, don't do this. This is right, this is wrong. All of these things. None of these things actually have any impact on the contingency. There are many families that we work with who many say the same thing. I just want my loved one to do this thing. And while I often understand that, sometimes the person is doing this thing not because they want to do the thing, but sometimes because they feel compelled to do the thing because something inside of their body is preventing them from interacting with their world in a more functional way. So there we go. We'll talk a little bit more about that as well later, because part of my contention is that not only does language not need to be necessary for the diagnosis of OCD, my contention here is that OCD behavior can actually occur in the absence of verbal mediation at all, and completely in the absence of the verbal community. All right, so before we take a break, we'll talk a little bit about differentiating autism RRBs from OCD compulsions as well. Autism RRBs, restrictive and repetitive behaviors, are a core diagnostic feature defined by repetitive behavior movements, intense fixation on objects or topics, strict adherence to routines, sensory processing differences. These behaviors often serve to self-regulate anxiety and provide sensory input for the person. They range in frequency, intensity, and are mandatory for the diagnosis. Some examples are listed here in terms of motor actions, hand flapping, rocking, spinning, repetitive verbal behavior. Person may engage in echolalia of repeating words and phrases, object use. Routine and rituals is important to recognize as well. Intense distress over minor changes in routine may actually be different from a person who has shown extreme distress with not being able to engage in a compulsion. Sensory behaviors as well, over or under sensitivity to light, sounds, textures, or special interests, intense narrow focus, all examples of some autism RRBs. In terms of how to differentiate autism RRBs from OCD compulsions, I made this little table to try and break down some of the main differences. So just in terms of a distress pattern, oftentimes autism RRBs are pleasurable, they're calming, the person is not distressed while they are engaging in the behavior. On the flip side, individuals with atypical presentations of OCD are often engaging in this behavior because of some anxiety. They are trying to do this thing to get rid of this thing or to get more of this thing. There's distress before and is temporarily relieved after. The person is generally distressed while engaging in the behavior as well. In terms of ego dystonicity, autism RRBs are more systonic. The person may enjoy or value the behavior. With regards to compulsions, it's more dystonic. The person shows frustration or resistance to their own behavior, sometimes showing frustration just with engaging in the behavior itself. In terms of functional impairment, with autism RRBs, there may be some extensive impact if the person's engaging in these behaviors throughout their day and is not really able to engage in other behaviors that are functional as well. But with regards to autism or atypical OCD, it's often progressive and increasingly interferes with daily functioning over time and consumes more time. From some of the families I've worked with, you hear the story and it starts with, well, the person just did it this one time, and now we're up to 4 hours a day that they're doing this thing. That's functional impairment. In terms of resistance, minimal resistance for autism RRBs with compulsions. Person has an internal struggle that may be evident in terms of their behavioral signs, hesitation, tension, conflicted expressions, responses, or even aggressive behavior. Cognitive components with autism RRBs, primarily sensory and stimulation focused, whereas OCD, it is often driven by what-if thinking or the need to prevent a feared outcome. And in terms of response to interruption, autism RRBs, people show some frustration, but generally can redirect without a major issue coming up. Individuals with OCD, there's escalating anxiety, panic, and aggression can happen until the person's ritual is completed or compulsion is completed in some way. So some easy ways to just characterize these two. RRBs are characterized by relatively consistent rate that is not strongly modulated by MO fluctuations. Flexibility and topography across variations that produce sensory input, similar sensory input, and response patterns that are not specifically tied to identifiable aversive antecedent conditions. Atypical OCD is characterized by a rate that is strongly modulated by the intensity of the condition internal stimulus. Extreme topographic rigidity, only one thing will get me the response that I want. And a clear temporal relationship between aversive antecedent conditions and behavioral initiation of the compulsion. So, all right, it is about 9:47, and this might be a good opportunity to take a break.
Great.
Or at least do some Q&A before break. How about that?
Yes, and I've been looking. I don't see any questions yet. Don't be shy, folks. If you have questions, feel free to drop them in, but we'll catch them on the back end in the second half. And we'll have time for Q&A after Scott finishes his slides. So feel free to drop those into the Q&A. In the meantime, it is 9:48. Why don't we meet back here right at 10? Make it a nice round number for everybody. And go ahead and take yourselves a break. Fill up your coffee or tea or water, and we'll see everyone back at 10. Thanks. My clock says 9:59, so I'm going to stick to the plan. We're going
Perfectly
to
fine.
wait till 10 for anybody who's on their way back. 10 o'clock. Here we are. Welcome back from the break, everyone. I'm just going to turn it right back over to Scott.
All right. Well, thank you, Miss Laura. Yep, we still have a lot to get through, so hope it was a good break. Let's get right back into it. Let's talk about some examples of atypical compulsion presentations. When we talk about that first distinguishing feature, the limited verbal of obsessions, atypical presentations, obsessions may be non-verbally expressed through behavioral indicators, the distress, the agitation. In terms of distress, it may not be what you always typically think of with regards to distress. Facial expression may indicate distress. Inability to communicate with others due to the presence of a triggering stimuli may be distressing for that person. Increased intensity of physical stereotypy as well. Just the other day, I was visiting with a family who said that for the last 3 years, they have not been able to go into the community without first, anytime they go out and leave the house, they have to first stop at a specific gas station and buy a soda. If they do not, things can go very, very badly and become very aggressive very quickly. All it takes for that person is distress. to get to that level of escalation, as well as the increased intensity of physical stereotypy, which is sometimes a behavioral indicator that the person is distressed while engaging in the behavior. On the other side, the agitation, irritability, vocalizations often are accompanied if the person is verbal. Body language may suggest that the person is agitated, tense muscles, balled up fists, things of that nature. Even controlling other people's behavior. Um, Directing attention back to a person during the conversation, utilizing another person in the role of a stimulus with abnormal intensity. I'll tell a story here in a slide or two about a mom and how this came to light during the assessment portion, during the intake portion, and completely changed the course of services and what we were doing with the family. In terms of the distress as well, going back to that, the inability to communicate with others. I met a young man last year who, in the process of doing the intake and the assessment with the family, they were talking about their loved one. He's a teenager, and for the most part, he is a very social young man. He utilizes his AAC device very well. And after observing him at his school, I was shocked to see that this young man is in an integrated classroom with many other typically developing children. And the classroom itself has so many people that it was overstimulating for me when I walked in. The fact that this young man was able to tolerate this environment showed me that he did enjoy and value the social interaction he was getting from his peers and the PA and everybody that was with him. And so, as we were talking about this, I said, well, does he like going to the doctors? The parents had identified that he always struggles when he goes to the doctors. And I said, has he historically always liked the doctors? And they said, yeah, I mean, for the most part, he's always been fine. But this new doctor that we have, he cannot stop talking about the automatic door that we go through when we walk in. I said, well, tell me about that. And they said, the moment we pass through that door, he starts saying door on his AAC device because he's rather fixated and fascinated with those automatic doors. And then from the moment we step foot into the building until the moment we leave, he cannot do anything other than talk about the door and hit that on his AAC device, almost like it was a stereotypy. I mean, just over and over and over. And even talking with the doctor, he's unable to interact because he's just saying door. And as we were talking about this, I said, so your son, who very much enjoys interacting with other people and historically has interacted well with doctors, in the presence of this particular stimulus, is unable to interact with others because of the distress caused by the stimulus with which he is fixated on. Is that my understanding? And they said, yeah, that's kind of what's happening. And it was a fascinating atypical presentation of even the distress. Their happy young man is unable to interact with the world around him. A unique variation on it. Atypical compulsions, unlike hand washing and checking, compulsions may appear more as unusual ordering and arranging that differs from typical autism-related preferences. Symmetry and order and just right phenomenon that is beyond autism-related preferences. Disney stickers on the iPad is a great example. So I have one young man that I'm working with, and in interacting with his day program staff, I said, okay, so tell me about his day. How's everything going? And they say, oh man, he's really busy. He's really active. He's always getting into stuff and he's always finding stuff. But I'll tell you, the last half hour of the day is great. He is so happy and just doing his thing. And every staff member had that same report. And I said, man, what is it about the end of the day that this last half hour, he is a happy camper just doing his thing? So I actually hung around that day until the end of the day to see what happened. And at 2 o'clock, they dismiss at 2:30. At 2 o'clock, he receives a Disney sticker if he has done okay that day. And so I see this young man take the Disney sticker and runs off to the corner, and he has an iPad or that has stickers on it, years worth of stickers. And so this gentleman sits down in the corner and starts putting the Disney sticker on. And then you can see in his body language and in his facial expression, it's not perfect. It's not just right. So yes, take it off and put it back on. And for the next half hour, that is all this young man could do. His vocalizations were distressed. His facial expression was distressed. His body language was distressed. But everyone around him, because he was not busy, because he was not getting into things, assumed that he was a happy camper. And I thought, no, this looks different than that. And until that sticker was in these perfect position, whatever that just right phenomenon is, he was unable to leave. So thankfully, he was generally able to complete this within that 30 minutes and then leave on transport without any major maladaptive change to his day. That's a different one, right? Tearing tags off of other people's clothing may be a instance of either just right or what is also known as just or not just right phenomenon. In atypical presentations, there is some literature to suggest that just right phenomenon may actually have a different presentation in atypical populations, and the not just right phenomenon is also a possibility. Not just right meaning whatever is happening in this environment is not just right, and I have to change something in order to get it just right to my liking. Bringing me to grabbing glasses off of the faces of strangers. I have one young man who we are still trying to determine what is going on, but he does have a unique target behavior where, in the presence only of strangers who are wearing glasses, he will run up to that person, grab the glasses off their face, and drop them to the ground quickly. Complete strangers, and you can imagine the chaos that ensues when sometimes this happens at Walmart unexpectedly to a random person. Um, following or supervising a parent or caregiver, tearing clothing for anxiety reduction, tearing stickers off items. All of these are other atypical compulsion patterns that have been observed and I believe need to be looked into a little bit further in terms of whether or not this OCD compulsion contingency is happening as well. Really what it comes down to is the ability for the person to tolerate that change versus the inability to tolerate change due to an unspoken rule. And that unspoken rule may be something that the rest of us don't actually know. Also, instances of excessive questioning or reassurance seeking that exceed developmental expectations, a contingency versus a compulsion. Instead of the person just asking for this thing, getting the answer, and that answer being sufficient, the compulsion is the person asking this question, even though they've received the answer 1,000,000 times, and it still is distressing in terms of whether or not the other person is safe. Is it a safety compulsion? What is it for that person? Repetitive statements, scripting, or the inability to communicate due to obsessive thoughts, repeatedly asking about a stimulus. Compulsions embedded within or disguised by autism-related stereotypies, loops within the ASD physical stereotypy. So I work with one young man who, as I told you about earlier, most of his day is engaging in some form of an autism RRB. He has lots of them that he engages in, and seemingly, as his mother and I have observed him many, many times, he engages in RRBs seemingly because some internal stimulus in his body is telling him that he has to do this thing in some way, shape, or form. As you're observing him doing this, you'll then watch as in the middle of one of these RRBs, something is not just right. And he begins having to do that same loop, sometimes for 45 to 60 minutes. So when we talk about that time consuming piece, he probably checks that box off the criteria as well. That is difficult and that is maladaptive to his life. He is unable to move forward from that RRB due to a compulsive cycle not being completed. There's also the situation of aggressive or self-injurious behaviors that serve that anxiety reduction function as well. Target behaviors disguised as escape or attention maintain behaviors as well. Um, so I was working with a family um, who was trying to discern if their loved one was engaging in RRBs or something else. And as we were discussing it, uh, they kept referring to whenever my loved one is doing this thing and I interrupt them, that's when I get hit. And so, after multiple variations on this theme, I asked one simple question. And I just asked the family, hey, okay, is it more likely that your loved one is going to be sitting on the couch one day, just watching TV, and they jump up from the couch, run over, and hit you, and go back to the couch and sit down? Or is it more likely that they're going to be watching their show, they stand up, start doing their thing, and when you come to redirect them or prompt them or do something, that's when they hit you? And they say, yes, that's what happens every time, right? Our loved one's perfectly fine. And then as they're doing something, I'm trying to redirect them, that's when I get hit. And I said, okay. So it feels like something else is going on. And they said, well, what are you talking about? I said, well, if you think about the ABCs of behavior, antecedent, behavior, consequence, it feels like there's something in between the A and the B. The antecedent is the same. Your loved one is sitting on the couch, right? But the behavior they engage in is very different. In one presentation, the person gets up, comes over, and hits you. It feels very impulsive, right? I have this impulse to come hit my loved one. In the other one, the person gets up and is doing their thing. And when they're interrupted, that's when the aggression happens. That feels more like it's a compulsion thing. Like the person has to do this thing. Is that accurate? And the family said, absolutely. They have to do the thing before they're able to feel relief. And I said, well, I think we have to have a conversation with the doctor about impulsive versus compulsive and maybe a different treatment strategy. Other examples of atypical compulsion presentations, context-dependent presentations. Unlike typical OCD, symptoms may intensify dramatically in specific environments or with certain caregivers. The young man that I work with that has the Disney stickers also had a unique other target behavior as well. The reason his referral came in was this young man was engaging in a very high intensity routine of physical stereotypy that engaged some low intensity self-injurious behavior for approximately 30 minutes every day after his day program. After looking at the data with behavior analysts, sure enough, it was happening only Monday through Friday, specifically after day program. On days day program didn't happen, this behavior did not occur at all. And it didn't happen on weekends, didn't happen on holidays, none of those things. After about the 30-minute mark, the person went back to their baseline level of respond. So as we were observing this and looking at all of the information, even the functional analysis had come back that this was an automatically maintained sensory behavior, but was unable to provide any form of sensory extinction or anything that would be incompatible to offer to the person to decrease some of the intensity of this situation. After looking at the contingency on multiple occasions, having the behavior analyst and myself do observations separately, it was determined that what happened was when this young man arrived home from day program, he walked into the house perfectly fine. But within the first 3 to 5 minutes of being in the home, and specifically in his room, you would notice a change in his demeanor. The intensity of his physical stereotypy, which he engages in throughout most of his day, increased significantly. And then he would begin by running down the hallway and vocalizing very loudly. When he was jumping up and down, he was large enough that he was knocking the nails out of the floor. It was very intense. And so The first time we had the conversation with the doctor, we explained the situation. And this doctor had been seeing this young man for many, many years and said, well, I just think it's the autism, and just kind of chalked it up to that. The second time that we met with the doctor, it was a different psychiatrist who, after hearing this same contingency, did at least hear that something else was going on and made a medication change that actually did have an impact. 4 weeks after the medication change, I walked into the home, and this young man's 30-minute routine was under 10 minutes. The intensity had gone from extremely high to fairly minimal. You really didn't know that he was engaging in an after day program routine. And that one was rather interesting for me. The next one, the case of the mom who couldn't talk, do laundry, or shower. That one's probably one of my favorites. So I got a referral 2 years ago for a young lady, and the referral was for physical aggression. This young lady's target behavior was scratching other people, specifically when people were trying to assist her in the restroom and getting her up from the toilet. And so, as I was doing the intake, I went to the day program. I observed this young lady. She did attempt to scratch staff when she was being assisted in the restroom. But it was when we went back to the house where things really, really changed. So after going back to the house with this young lady and meeting her mom, for the next hour and a half, I sat down on the couch with mom and her daughter. And for the next hour and a half, mom and I had one of the most difficult conversations. As we were doing the intake, for the next hour and a half, her daughter was vocalizing fairly loudly, as she was doing this, she was also trying to bring her mother's face and control where her mother's eyesight was, and bringing her mother's attention constantly back to her for the entire hour and a half. And I said, Mom, is this a common thing? And she said, well, yeah, I mean, she doesn't really like it when I talk to other people. And I said, well, let's talk a little bit more about what's going on for your young lady, because I'm here for physical aggression, but this seems to be impacting you as well. And sure enough, mom and I started a conversation about what else was going on. And come to find out, mom had not been able to do a load of laundry by herself for the last 10 years. Was an example of the fact that her daughter followed her around throughout her house, all through her day. No matter what she was doing, her daughter had to be in the same room. Eventually, we got to a part in the story where her mom felt comfortable, I believe, telling me, and she said, Scott, I'm going to tell you something that I don't tell many people, but I feel like based on our conversation, I can tell you, and it's not going to sound weird. I haven't been able to shower by myself in probably, 5 to 10 years. And I was like, what? And she goes, no, it's not creepy. It's not some sexual thing or anything weird like that. But like when I say my daughter follows me around, I can't take a shower without her being in the room. And I said, well, what do you mean? And she said, when I go to take a shower, I go into the shower and my daughter's standing in the room the entire time I'm in the shower. And then once I turn the shower off, she tells me to open the door. She tells me to grab the towel. She tells me to dry off. And then we move on with the evening. And we kept talking about these type of situations. And we kept talking about the change that she would see in her daughter before these things would happen. Her daughter, who was typically a generally happy person, as these things would happen, it was similar to other instances. You would notice a facial expression change. She would begin vocalizing. She would look and appear distressed and would try to or attempt to control the other person into doing something. And until that thing was completed, she was not able to be provided relief. Once that compulsion or that thing was done, she was able to move on with her day without any issues. And so, after having this conversation, we did a few more observations, and again, the contingency absolutely appeared to fall in line with that atypical presentation. Mom was a dentist and eventually sought out another friend of hers and who was a doctor who said, there might be something to this. And a short time later, their doctor made a medication change. And I'm happy to report that 6 months later, that young lady was being looked at for a residential provider that she was very excited to be able to move on to that opportunity. And a lot of it had to do with actually getting on the right medications. My favorite part about that whole situation and working with that client and that family was about 4 weeks after the conversation and the medication change, I stopped to the house. And when I came in, I was there about 15 minutes talking with mom before I realized and remarked to mom, "Hey, mom, we've been sitting here for 15 minutes and having a conversation without your daughter trying to control your behavior. What else is different?" Mom reported to me that she had been doing the laundry by herself. But my favorite was asking about the showers. And she said, "Scott, for the last 2 weeks, I've taken showers by myself." And I said, "Where is your daughter when this happened?" And she said, "She's been sitting in the living room downstairs for the last 2 weeks." And I was absolutely amazed. It was almost as if as this young lady's mind and body felt better and less distressed. She no longer had to engage in these compulsions to seek that conditioned relief. Compulsions may be also more situation specific and more appear more behavioral than ritual based. The toys in the vents. So I worked with a young man who engages in a little bit of hoarding. He takes other people's items, usually small, insignificant items. And over the course of time, there was a massive quantity of other people's belongings found in his specific area of the home. But I think the more fascinating one for me was when I finally got an email from BCBA who said, "Hey, we were doing a room check this weekend to make sure that there wasn't anything else in the person's room in their possession. And we found something in the vent." And I said, "Well, what's in the vent?" And somehow this young man had found a vent that was directly behind his bed and had somehow moved his bed out and unscrewed the screws and was placing his most prized possessions in a specific vent in the group home and then screwing the vent back on and keeping everything. And apparently this young man had been doing this for approximately 5 to 6 years and had his absolute favorite toys that didn't distress him or did distress him to actually get rid of. He had all of those hidden in one area. When that was found, obviously that became the most distressing thing for him. But it seemed much more behavioral to everybody around because he was constantly doing these things. But there was a specific set of toys that were more ritual based, and those were the ones that he had to hide. And they happened to be Matchbox cars, which fit very nicely into a vent. The individual may also show extreme distress when unable to complete compulsions, but struggle to explain why. When I was supervising that group home for young men with autism many years ago, I will never forget doing intake with one young man. And as I was talking with the previous behavior analyst, I said, "So can you tell me about, when this OCD-like behavior, really was at its worst?" And they said, "Well, sure. There was a point in time where when this young man went to school, his residential placement was connected to his school. And when he came to the school and when he exited the school, it was, we had to put the entire school on lockdown." And I said, "What do you mean?" And she said, "We had to put the school on lockdown. Every room in the school was locked as he was in the hallways. And he also had a 5-person escort." This young man at the time was about 12. A 12-year-old boy uh, was so obsessed with the movie Toy Story that if he thought for a second that a copy of the DVD of Toy Story was in that classroom, He was going to go through all 5 individuals and a solid metal door to get that DVD. And that is pretty extreme. He was unable to say why. He was never going to be able, and to this day, this young man was never able to say what was causing him to feel this way. All we knew was the outcome of if he wasn't able to engage in these compulsions. Within the first week that I was serving this young man, he had come out from taking a shower on day 2, and he had asked for a long sleeve gray shirt. He didn't own any. And so the next thing we knew, he began engaging in headbanging. And after a visit to the ER to make sure that he didn't have a concussion, his mother arrived to the house with about 10 pairs of long sleeve gray sweatshirt or gray shirts that this young man probably wore for the next 6 to 7 years until another preference of what he wanted to wear took over. It was still, to me, one of the most fascinating examples I'd ever seen of how strongly those atypical compulsion presentations can happen, and we're never going to be able to get the insight of what it is that's causing that person to engage in that compulsion. Some of the other examples here, compulsive checking disguised as perseveration. Had a young man who was watching their neighbor. Anytime the neighbor went back into their house or closed their garage door was critical chaos for this person. The person would engage in crying and sobbing and vocalizing some self-injury until they were certain that the neighbor was still present within their home. Self-injurious behavior as anxiety reduction as well. I was working with a young man who, interestingly enough, a couple of years ago, it appeared as if, and I didn't work with them for an extended period of time, but it appeared as if this young man was engaging in self-injurious behavior somewhat compulsively to decrease his own anxiety about what was happening. For example, this young man oftentimes had to be assisted by his parents from hitting himself. They would have to sometimes hold his arms. And so one day I was at the house talking with the parents. This young man got up. He went over to the refrigerator. He got himself something to drink. Everything was fine. On his way back to the couch where the mom was, he began engaging in self-injury somewhat lightly. He signaled it to his mother and made sure that she was able to block him from doing it. And he generally, the topography he engaged in was with both hands. He waited on hitting himself with the second hand until dad was close enough to be able to stop himself. It was almost as if I'm anxious that I can't be held on both sides, so I have to do this until both of you are holding on to me. It was a unique presentation and a compulsion that I do wish I would have had more time to observe and understand. In terms of some hoarding presentations, hoarding, which is now separate from OCD, frequently co-occurs with both conditions as well. Atypical features of hoarding presentations may include hoarding non-functional items such as trash, food wrappers, broken objects. I have worked with a number of people over the years who have engaged in these type of hoarding non-functional items. And for many years, it was, even as a behavior analyst, I would say, well, it's automatically maintained. I don't know what to do. We got to figure out something else that they would like. Not necessarily understanding that it may be some feature about that thing or an unspoken rule we don't understand. And it has more to do with that internal stimulation the person is feeling. Aggressive or self-injurious responses to discarding, hoarding items. And just to talk about that quickly, I worked with a young man many years ago when I was working in Tennessee, and he collected newspapers, in particular Sunday newspapers, and he had been collecting them for years. He had an entire closet in his bedroom dedicated just for Sunday papers over the last several years. And in the 4 years that I worked with that young man, the only time that he was ever hospitalized, he was hospitalized, and the nurses at the hospital kept saying that he kept repeating a specific date over and over and over, and nobody understood why. After about an hour in a meeting, I asked the house manager to go to the house and check his newspaper stack. And sure enough, the one missing newspaper somebody had taken was the one date that he was reported. He knew of every single newspaper that had been in that stack, and he was aware that one was gone. And that is the only time that young man was hospitalized in the entire time that I was working with him. It was a fascinating example of it. Other examples: inability to articulate reasons for saving the items. I don't know why I keep this stuff. It's just I have to, as well as it can present with health and safety risks as well. The attachment intensity theory that was proposed back in 2014 suggests that individuals with autism may develop unusually intense attachments to objects due to social communication differences. If you combine that with OCD-related loss of fear or fear of loss or incompleteness, severe hoarding can emerge. The Mortal Kombat paper army. All right, quickly about that one. I began working with a family a few months back, and immediately upon walking into the home, I was fascinated by the coffee table that was covered in these little paper statues that had been hand drawn, cut out, and they were all over the coffee table. And I go, oh, well, this will be fun. So I walked up and I said, hey, my man, what you got here? And he goes, these are my figures. And I said, awesome. What are they? And he goes, they're Mortal Kombat. And I said, oh, I love Mortal Kombat. This is great. Oh my gosh, what do you do with them? And he's like, oh, yeah, they fight in this. And in the background, I heard mom say, oh, yeah, you should have seen when they were all over the walls. And I said, I'm sorry, what? And she goes, yeah. He didn't just have them on the coffee table. Back last fall, these were all over every wall in our living room. And if somebody came up and tried to touch one, oh, it was bad. I said, well, what do you mean it was bad? He'd become very aggressive. And so I turned back to my young man and I said, hey, my man, what is it about people touching these figures that is upsetting? And he, without looking at me, said, they're for display only. And I understood that there had been a rule ingrained. Some internal response was these things were only for show, and if anybody else touched them, it was going to be problematic and cause more aversive stimulation within his body. He has been an interesting character to work with, and other unique compulsions that he expresses as well. All right, so in terms of behavioral escalation patterns, just really quickly to hop over the slide because we are getting down to the last 25 minutes or so. In terms of that behavioral escalation or the response a person might have that to being interrupted from completing the compulsion, a critical atypical feature is a behavioral escalation when compulsions are blocked. And in those instances, in 68% of the cases, aggression can happen when a person is prevented from engaging in the compulsion. In 54%, self-injurious behavior can happen as well if the person is unable to complete that compulsion. It's as if the intensity of these responses suggests that there is profound underlying anxiety underlying these compulsions. Not being able to complete it may have a lot to do with why the person is doing it in the first place. So, how is this stuff not being figured out more often? Diagnostic overshadowing occurs when symptoms of one condition prevent recognition of a co-occurring condition like OCD. Like the doctor that I worked with many years ago who told me that people with autism don't have OCD. How it happens? The assumption of it's just the autism. People attribute all of those symptoms to known neurodevelopmental conditions. They've always been rigid. It's just part of the autism. The problem is that this reasoning prevents further investigation, even when symptoms change significantly from baseline or are completely different from something the person had done previously. So how this operates is the expectation bias. Once a diagnosis is established, observers unconsciously filter new symptoms through that lens. Compulsive behaviors are seen as just stimming or perseveration or an RRB. Anxiety is attributed to communication difficulties. Behavioral escalations are viewed as challenging behaviors requiring management rather than symptoms requiring treatment. Standard OCD assessments require verbal articulation of obsessions and insight into irrationality, but individuals who can't express internal experiences are excluded from this diagnosis. And when standard criteria are met, OCD is ruled out rather than assessed differently. Clinicians may just lack training in recognizing those atypical presentations as well. And how does this impact the people that we serve? If OCD just goes unrecognized, it can be completely missed for sometimes years or decades. I did a talk about the stigma of mental illness a couple of years ago, and it suggested that from the first time that a person experiences anything to the time that they get a diagnosis, sometimes in mental illness, the average is 7 years. 7 years. So if the person, your loved one, begins expressing these atypical OCD compulsion patterns at 14 years old, that suggests that they may not even be diagnosed accurately on the low end until 21 years of age. Delayed diagnosis. OCD is eventually identified only after severe impairment or crisis, or when earlier intervention could have prevented deterioration. Most people that have come in contact with me, and it has been some atypical presentation, they've been in a crisis situation. You don't get SST services because you're having a great day. It also will result in inappropriate interventions. Behavioral approaches focused on compliance rather than anxiety reduction, utilizing behavioral interventions that are not actually decreasing the functional relationship or the probability of the behavior. Also, medication trials targeting aggression or behaviors without understanding underlying OCD, restrictive interventions as well, progressive impairment. Without treatment, OCD typically worsens, consuming more and more time and causing greater distress. All right, so let's talk a little bit about polypharmacy as well. When OCD goes unrecognized, a characteristic polypharmacy pattern often emerges. Polypharmacy targeting multiple symptoms, progressive symptom worsening, individual requiring increasingly restrictive settings, or a pattern of behavioral crises. So here's what I have generally seen. A family has a loved one, maybe with autism or an intellectual disability. The person shows some OCD-like behaviors, and at some point in time, those OCD behaviors get out of hand and get work and maladaptively affect the person's life. Person and the family goes to a doctor and they say, hey, my loved one out of nowhere is getting really upset, and then they hit me when I go to redirect them. What are they doing, doc? And to the doc, it sounds like they're impulsively hitting when they are just being asked to do something reasonable and socially acceptable. And so for the doctor, they think it is an impulsive thing that this person is doing, and generally provides an antipsychotic. And within 4 to 6 weeks, that person begins showing side effects or has a complete change in behavior because the treatment strategy is not actually treating the underlying issue. Eventually, in multiple cases, and part of the reason why this talk came about was I had these situations coming up. And in these situations, when we were able to determine that there was a possible atypical OCD contingency happening and be able to provide that information to the doctor was able to hear us out most of the time, change the treatment strategy to an SSRI, and see if there was going to be any effect on the compulsive behavior of the individual. The reason why I bring that up, obviously, is because of the approach of the antipsychotics. Multiple antipsychotics for behavioral control is a common pattern that happens. Prescribed to manage aggression, agitation, or self-injury. The doses escalate as symptoms worsen. You'll often see individuals on a number of medications or at much higher doses. Person is generally also experiencing side effects as well: sedation, weight gain, metabolic issues. Symptoms persist because the underlying issue is not being treated. Another polypharmacy pattern that often happens is mood stabilizers for mood lability. I've seen this one as well. Described for what appears as emotional dysregulation, right? A person gets upset out of nowhere, and it only happens under certain circumstances. So obviously that's a high and a low. Individuals actually experiencing OCD-related distress with compulsion completion. And it generally results in limited effectiveness because the primary issue is anxiety-based and not mood lability. Another common pattern that you'll see is sedatives for anxiety. Person is getting very distressed by not being able to complete the compulsion, and so the doc has ordered a benzo, a PRN benzo for acute distress. And you'll see an increase in the PRN usage because the person is distressed in the specific context. May provide temporary relief, but it doesn't address the OCD maintenance cycle. For about 4 hours, person may be a little chilled out, but oftentimes with rebound effect, the contingency is reestablished almost immediately. There's also a risk of dependence and tolerance. And the last one that I want to talk about is those PRNs. Oftentimes I see it as the sedatives for anxiety, but sometimes the doc just refers to it as a PRN. But it's a heavy reliance on crisis medication. And that's oftentimes what you see in these situations. A person has to see it in almost every context in which the eliciting stimuli happens. Reactive rather than preventative, rather than proactive approaches, these PRN as needed are happening after the person has already engaged in extreme distress. And the individual remains in chronic distress regardless. So what does all this polypharmacy stuff mean? Individuals can sometimes be on 4 to 6 psychotropic medications. I've seen individuals when I come on board on 2 to 3 antipsychotics, same antipsychotics, doing the same thing. And there is no research to suggest that 2 to 3 antipsychotics is any more effective than one that is actually doing its job. Side effects impair the quality of life for the individual. The underlying OCD continues to progress. It helps to obscure our clinical picture, making multiple medications, and the changes that occur with them, making it difficult to assess. The sedation may also mask the anxiety, making OCD actually harder to recognize. Behavioral suppression doesn't actually equal symptom resolution in any way. In terms of more specific treatments, SSRIs at therapeutic doses, oftentimes you'll often find individuals who may have some OCD and may actually be taking an SSRI and still be at the starting dose that they were at 8 years ago when they first started taking the medication, never having had an increase with multiple increases or changes to antipsychotics. There's behavioral interventions could provide substantial relief but are tired, and there are obvious systemic costs as well. With regards to communicating with doctors, behavior analysts, assessment documentation should address several specific questions. In terms of behaviorally, we should be asking, what is the evidence that the behavioral is not socially mediated? As behavior analysts, we need to rule out social positive and negative reinforcement as primary maintaining variables, which reduces the likelihood of behavioral phenotype misidentification and directs the physician towards neurobiological etiologies. What is the evidence for the antecedent-driven behavioral initiation? What are those things that we can see? What is the change? Is it a facial expression, body language? Is there something that the person is showing us, a signal of that person's change? And what does response inflexibility data tell us about reinforcing properties of chain completion? In terms of pharmacological implications, we should be directly addressing these things with physicians as well. If the FBA data are consistent with conditioned aversive interoceptive MOs, and if the behavior intervention alone has been insufficient, then the behavior analyst should explicitly note in their consultation that the presentation is consistent with pharmacological treatment targets associated with OCD and request that the physician consider this. Now, I say this, but I do want to note that this is not a medical recommendation. We should not be telling doctors this person has OCD. What we should be saying is, here are the reasons that I feel that the person is meeting these clinical markers. Because what we're trying to provide is an accurate behavioral characterization of the clinical presentation so that the physician's diagnostic pharmacological framework can be utilized. In the interest of time, I know Laura is going to share these slides with everyone. For the behavior analysts in the room, I do have some proposed FBA modifications in terms of how to do some different things with regards to functional analysis. But in the interest of time, I want to hop over to one last point that I want to make. All right. So I want you to hear me out for just a couple minutes. Try to get this out there. Earlier, I'd made reference to the possibility that OCD behavior can be established behaviorally and happen in the absence of verbal mediation. And I want to make that case again. So let's consider the case of a nonverbal individual who engages in the target behavior of pulling tags off of other people's clothing. Person sees a tag on somebody's clothing. Person begins to show observable distress. They remove the tag and immediately drop the item, and the person calms immediately and goes back to what they were doing. In this contingency, no verbal behavior is required. No stimulus equivalence is required. No relational framing. No concept of right or wrong is required. The entire behavioral pattern exists without any evidence of symbolic verbal mediation. So this raises an important question. What exactly is being experienced by the person? As I was thinking about this, I thought a radical behaviorist might actually say an organism may simply be responding or experiencing an aversive physiological event, and nothing else needs to be assumed. Skinner, back in Verbal Behavior, treated verbal responses as behavior controlled by variables in the environment, including private events. So when somebody says that feels wrong, right or wrong, Skinner would not treat that as a window into the person's mental state, but rather as a tact, a verbal operant that had come under the control of some discriminative stimulus, in this case, a private one, a thought. So that same contingency I just described, in Skinner's analysis, the visual stimulus of the tag would occur. The person would experience a private aversive respondent reaction. The compulsion would then be initiated, the escape behavior of tearing the tag, which would terminate the aversive stimulation and cause relief, which then would be negatively reinforced. The verbal report of "it feels wrong" is not actually part of this causal chain. It's a parallel product of the same controlling variable. Even in the context of a neurotypical individual, if the same behavior happened with somebody who was verbally able to conceptualize and express a obsessive-compulsive thought, the verbal report of "it feeling wrong" is a parallel product of the same controlling variable. The organism that tears the tag and the organism that says it feels wrong are both responding to the same thing, but one response is motor and the other one is verbal, meaning that the person is responding to whatever's happening inside of their body. But when asked, why did you do that? They say, well, I don't know. It felt wrong. That piece of what they were doing was controlled by the verbal community around them. Notice that concepts like right and wrong, incomplete, unacceptable never appear, but the explanation remains entirely functional. And even in situations where a neurotypical, verbally able person is engaging in a similar form of behavior, when this contingency happens very quickly without any verbal discussion or any verbal mediation, the entirety is still consistent across the account. Simultaneous stimulus contact, micro distress, compulsion relief, and all of these things happen in the absence of other people. There's no need to suggest or speculate about a sustained cognitive process. Contingency can close in seconds. Skinner acknowledged human beings learn to label private events through a process that is inherently imprecise, because the verbal community can only train tasks for private stimuli indirectly. Child learns to say pain because caregivers observe the child engaging in behavior that is consistent with what people look like when they're in pain, and then differentially reinforce, oh my gosh, you look like you're in pain. And the label is then learned as an approximation. With OCD, the sensation that the person is experiencing when they see that stimulus that elicits that response is primary. The verbal label that we bring to it is secondary, right and wrong, good or bad. And for some individuals, especially nonverbal individuals or individuals with social communication deficits, that label may never emerge at all. For verbally fluent adults, the process actually happens with the sensation, the label, and the compulsion. But the label may be completely epiphenomenal. For a nonverbal individual, someone even with limited stimulus equivalence, it may just be sensation, compulsion. That internal stimulation makes me engage in that compulsion. But the behavioral outcome is absolutely identical. So Skinner would say that the verbal community taught the fluent person to emit wrongness under the control of a particular class of private stimuli. That training never occurred for the nonverbal individual, but the private stimulus of that aversive internal stimulation was still present. The escape behavior still occurs, and the reinforcement contingency still operates. What I'm questioning here is whether or not the verbal community, the verbal introspection that we have, are those things discovered through introspection and our interaction with the verbal community? Are they necessary? Or are they actually constructed through verbal training laid over a pre-verbal sensory process? Even RFT doesn't sit there and say that aversive stimulus functions are relationally derived. It's committed to the claim that relational framing expands and elaborates. So RFT would say the nonverbal individual, direct conditioning is doing the work. For the verbally fluent individual, derived relations are actually amplifying the original conditioned functions. What this would suggest, and what this theory suggests, is that the verbal component to whether something is right or wrong or should be done actually is amplified by the fact that people are verbally fluent individuals. I know we're short on time, so big picture here. Is it possible that at least some presentations that involve cognitive mediation may actually be operating on the same direct contingency as the nonverbal individual? So if this hypothesis is correct, the target interventions that target the verbal elaboration of right and wrong or extinction may never actually be looking for or intervening on the thing that was actually in the causal chain. The sensation that precedes the compulsion may require a different kind of intervention, perhaps one focused on direct extinction of that direct aversive stimulus. And ultimately we may have to look at it just a little bit different. So, and, uh, oh, I guess that's it. Oh, there we go. There's the last one. Um, so that's it. I'll leave. Sorry that there's not a ton of time for question and answer. I'm more than happy to answer any questions and stay a couple minutes after if need be. But thank you all so much for coming to my presentation and hearing my little thoughts on atypical OCD.
Thank you, Scott. Your humility is impressive, but I thought it was great. Thank you so much for that information. Here's what we're going to do. I'm going to give my little wrap-up housekeeping thing here, but we do have 3 questions in the Q&A.
Okay.
So I'll do the wrap-up real quick first, and then we'll do Q&A for anyone who can stay for a couple minutes. So I just want to make sure I thank you. And I want to thank everyone else who attended today. Super appreciative for you spending your time with us. Please see the links in the chat that Melissa is chatting now for the evaluation and the post test, both of which must be filled out in order to be eligible for CEUs. You will also receive an email today with those links. If you do not, please feel free to get in touch with us through Eventbrite. We're happy to send those to you again. You have until Friday, August 14th to fill out the evaluation and do the post test. We cannot make exceptions and we can't grant extensions. So please make sure you make it by that date. So thanks again, everybody. So now let's get into the Q&A. Jennifer asks, what are the key differences between an impulsive behavior and a compulsive behavior? I have a student who I believe has ASD who engages in behaviors while transitioning in the hallway in school that do not happen 100% of the time, but he appears to not be able to stop himself, and disruption causes significant escalation.
Wow, that's an interesting one. Yeah, it is tough to try and figure those things out. Yeah, I have a similar situation right now with a young man who, the one that takes glasses off of other people, as well as he has another unique behavior of impulsively hitting you when greeting you. So when I come in, I usually get hit right above the eye. Um, and he's nonverbal. He's unable to tell you what it is that he's doing. There are periods of time that it looks like he's just so excited as if, oh my gosh, you're here. And so he has to do this thing. He's not generally trying to harm the person. And it is not completely consistent either. I could, out of 10 times I go into the house, it probably happens only about 7. The If the person has some insight, you might be able to ask them a little bit about what it feels like before that happens. There may only be a moment before they feel like, one person who we were recently talking to about this said that when they have that compulsive feeling, it feels like a bunch of pressure in their head. And I thought, oh, that's an interesting way to characterize it. And so maybe asking the person, is there something you feel just before having to do this thing? Are you able to stop yourself? Are there times or situations where you are able to stop yourself? Find out if it is context dependent on only at school and in the hallways. Does it happen in classroom? Does it happen at home? Try to figure out all of those variables and see if you can determine if there's that complete contingency. Does the person actually get any relief after hitting the other person? If not, then it may not be having that condition relief function as well. Maybe an impulsive thing. So it's a great question, though.
Great, thank you. Okay, 2 more. Maya asks, is there a way to catch early symptoms or behaviors despite the late onset regarding children and catching the diagnosis early?
I think the biggest thing to watch for early on is just watch for changes in your loved one that may indicate distress, even if it's not typically what we would think of as distress, right? The little guy that I was working with who got very distressed when his neighbor went in the house, he generally was a happy camper throughout his day. And so it was those times where he would get very upset and very emotional and very sad about things that we had to start looking at. Was that something where it was telling us something was changing for him?
Got it. Okay, thank you. One more, last one. Can this
Mhm.
be confused with what is described as pathological demand avoidance? that the need to complete the compulsion causes the escalation rather than the demand to stop the behavior causing the escalation.
Yes, I absolutely believe it can be,
Mm.
and probably is often either um, uh, overshadowed or misunderstood because of those two things. So you have to kind of figure out which one it is. Because yes, the person, it probably looks like avoidance or demand avoidance. And is it possible that the person actually has an obsessive thought about an unspoken rule that the rest of us don't know about? Or is it simply that the person's avoiding this behavior in some way, shape, or form? So yeah, a good question though. Yeah.
Well, thank you so much, Scott. Folks, we're only 2 minutes over. Good job. And thank you, Scott, for sticking around for a couple minutes. And thanks everybody else for sticking around for a couple minutes. Um, we are going to call it a day. I want to wish everyone happy Friday. Thanks again. Fill out your evaluations and post tests and get in touch if you have any trouble. Okay. Thanks so much, Scott.
Thank you guys. And have me back anytime. I'd be more than happy to come
We'd love
back.
to.
So,
Thank
all
you.
right.
All
Thank
right.
you.
Take care.